Trained as both a pediatric neurologist and a clinical neurophysiologist, and much of my interest has always been in the central nervous system, specifically in the brain. And so, what I've been asked to talk about today is sort of our demyelinating diseases of the brain, and particularly in the pediatric population. So. And then tomorrow we'll hear about demyelinating disease in the spinal cord and ADEM in the pediatric population. Okay, let's see, how do I bring up the first slide?
Ask her. She's got it covered.
Yeah, I'm set. This is right click. Right click. Okay. All right. So the title of my talk, of course, she's already mentioned, and today what I'd like to do is spend a majority of my talk on pediatric multiple sclerosis, and we've already talked about that some already, but I certainly want to delve into a little bit more detail than previous speakers. And then at the end, we'll talk a little bit about how do you distinguish pediatric multiple sclerosis from pediatric ADEM and pediatric TM. So this first slide talks about the journal article in 2004 by Myelitis et al. That included children under 16 years of age from 12 pediatric neurology centers in France. And they were asking about how frequent it is CNS demyelination disease in the pediatric population. And we've talked about most of the characteristics of these patients already. Their follow-up period was almost about three years, but with 20% of those less than 5 years. There were 296 total patients, so they certainly were a lot of patients in this particular study. And we talked a little bit about before with previous speakers, talked about the average age of onset of the particular diagnosis that we've been discussing. For pediatric MS, it's roughly around 12 to 15 years of age. For monophasic ADEM, which is probably of these three diseases, probably the most common of them in pediatrics, it usually presents at about 5 to 7 years of age. And a single focal episode, which is usually transverse myelitis, it presents at about 8 to 9 years of age. So I'm going to spend most of my time on some of the distinguishing characteristics on most of these particular slides. As we've talked about before, infection during the preceding month is much more common in ADEM versus TM. It was very high when you just had a single focal demyelinating episode. Optic neuritis is much more common in multiple sclerosis, although it can happen in pediatric ADEM. And brainstem dysfunction overall was much more common in ADEM, as well as mental status changes were also more common in ADEM. And that particular last point is one of the points that I always drive home to the residents, that a change in mental status associated with a hemiparesis and ataxia in the setting of a child who's had a preceding episode is usually ADEM until proven otherwise. So the MRI findings we sort of already have talked about a little bit. With the initial MRI, if it did suggest ADEM, the final diagnosis usually was ADEM, and only 15% of the time did the final diagnosis end up being MS. But if the MRI looked like MS, it turned out to be MS in 57% of the situation, and none of those kids ended up having ADEM. The distribution of the MRI lesions, really only two things I want to point out here. First off, especially for the physicians or especially the residents who are here, when you see demyelinating lesions in the thalamus or basal ganglia in pediatric disease, it's usually ADEM for the most part, versus if you have gadolinium enhancement, it's usually multiple sclerosis. So, and the other ones are sort of scattered throughout and are not really that distinguishable. CSF findings, most of the time kids who had a pleocytosis tended to have more ADEM than they had multiple sclerosis. And the same thing for elevated protein. If you found an elevated protein, you usually had ADEM much more commonly than MS. The other thing that's very distinguishing about the CSF, and this is one of the things I always emphasize to the residents, is that when we send off oligoclonal bands, you almost never see it in ADEM versus it's positive in pediatric multiple sclerosis patients in about 40% of the time. So predictive factors of a second attack of demyelination, I think we've already talked about, and these are all suggestive of pediatric multiple sclerosis. An older age of onset, the presence of myelitis or optic nerve lesions, and an MRI that's suggestive of MS and onset, versus those that would predict that you wouldn't have a second attack of demyelination, the suggestion that you have monophasic ADEM on the initial MRI. So pediatric multiple sclerosis, there's about 400,000 patients roughly in the United States with multiple sclerosis, and somewhere, the 10 to 15% of the range the kids will have presentations under age 18, and most of those kids tend to be in the teenage populations. Very, very uncommon. It was actually recognized in the 14th century and in Saint Ludwina, who I don't know, but evidently she was in Holland, and she had both visual symptoms and sensory symptoms with a relapsing remitting course. So it's actually it's actually described in the early literature of the Middle Ages. And the earliest documented autopsy case is actually about 10 months of age. So it can happen in very, very young infants, but it's very, very uncommon. So the diagnosis is really as much the same as it is in adult patients, 2 or more discrete neurologic events that are separated in space and time. Optic neuritis and sensory symptoms tend to be the most common with children who have pediatric multiple sclerosis. Motor symptoms are usually very, very low in the primary presentation. And the thing about kids and demyelinating episodes is very, very important to realize that kids have a very rapid onset of demyelinating disease. So it can make you think about stroke, it can make you think about encephalitis or other things like that. But you need to remember that even things like multiple sclerosis or pediatric TM has a very rapid onset. It can be hours to a few days, and in a majority of children. Lab features with pediatric multiple sclerosis are relatively benign. About 60% of the kids actually have normal CSF, but they can have lymphocytosis or increased protein. But what we see very commonly, and most of the kids who I have in my clinic with MS usually have this increased CSF IgG synthesis or the increased MS index. And as I said, the oligoclonal bands can be present in children, but sometimes they don't appear until the convalescent or the relapse phase. So sometimes it's nice to send it a second time if you're thinking about it. Since I am a clinical neurophysiologist, I always talk a little bit about evoked potentials, and those of you in the room who have had evoked potentials know what I'm talking about. So there are 3 things that we test in the neurophysiology laboratory: visual evoked potentials, somatosensory evoked potentials, or brainstem auditory evoked potentials. The ones that we usually do in our pediatric patients are usually the visual evoked potentials, and really at the time of the first attack, most of them, about 95%, tend to be positive, and it's a helpful sign versus in ADEM, oftentimes these evokes are actually normal. Actually, MRI can be helpful in this situation. About 50 to 65% of the kids will actually have definite imaging criteria for MS. But kids tend to have a smaller number of total lesions on presentations, and they tend to have more of these ring-enhancing lesions at times. And the final point at the bottom, ADEM you tend to have gray matter lesions and lesions in the basal ganglia versus the periventricular lesions that tend to be more typical of pediatric MS. So the pathogenesis, I think we've heard about that ad nauseum here so far. The one thing that I did want to point out is that there are some susceptibility loci for demyelinating disease, especially multiple sclerosis. On chromosome 6, there are two MHC2 alleles, DR15 and DRQ6, which is greatly increased in terms of the numbers or amounts found in multiple sclerosis patients. But there certainly is interactions of environmental factors such as viral titers, geographic distribution. All of the genetics in this together are really exploited in the concept of molecular mimicry that has been thought to have been responsible for MS. So for multiple sclerosis in pediatrics, there actually was very, very little data, and I certainly am very grateful to Ben for presenting that TM data. That was actually terrific, and it certainly gives me some new things to be able to do in the acute period. As far as chronic therapy goes, we do use the interferons, all three interferons in pediatrics. And we have just a little bit of data that's actually in the literature that helps us out. Avonex, Rebef, and Betaseron, we have used all three of those. And their side effects that you see in pediatrics are very, very similar to what you see in adults: fevers, headaches, myalgias, flu-like symptoms, etc. Most of them are transient and actually can be improved by pre-medication. Sometimes you can get elevated liver function test, which will go away if you discontinue the med, and sometimes you can restart the meds, and that is helpful in terms of treatment. Now, there are about 25 of the 43 patients that were talked about with Banwell et al. In 2006 discontinued these medications or the interferons. So about half of them, after about 111 weeks, or roughly almost not quite 2 years, either because of a lack of efficacy, injection pain, or a change in diagnosis of some sort. So not every kid stays on it. But actually, 38 of the 43 patients had a reduction of their annualized relapse rate by about 50%. And there was another study reported by Gehesi et al. That showed a similar reduction with Copaxone and the interferons from a rate of 2.8 episodes to about 0.5 episodes for an ARR. So there's at least some evidence, anyways, that in pediatric populations these medicines can help with relapse rates. Okay. There is not much data for the use of Tecibra, rituximab, or Dovantrone in the pediatric world. I know these are used by some of our MS specialists, and I always defer to them to actually use some of those because I've used these very little. The one thing I have used is to try to prevent attacks if the interferons or Copaxone doesn't work, is the IVIG Q monthly. And I used it at about 0.2 grams per kilo IV per month. And there's a couple studies that showed that it reduced the clinical attack rate by about 50% and reduced the lesion burden by about 60% in the literature. So some evidence to suggest that IVIG per month may actually help with the relapse rates. Okay. So let's try to distinguish this particular disease from pediatric ADEM. So as we've talked about before, ADEM is an inflammatory demyelinating disease, usually after viral infection in kids. Sometimes you see it under vaccines, but usually after viral infections. Typically, it's monophasic in about 90% of the kids. There are about 10% that have multiphasic disease, at least it's said in the literature. And about 3/4 of the kids usually have some sort of preceding infectious event or vaccination event that usually occurs about 1 to 4 weeks before the onset of neurologic symptoms. And the interval between the febrile prodrome and the neurologic symptoms is it's said to be 12 to 14 days in the literature, but in my experience, it's more like about 5 to 7 days. And as we said before, the age of onset typically tends to be younger. And this is a slide that's actually out of order, so I'm going to go on here. Prodromes, about percent of the kids will have some sort of nonspecific URI, and about 11% will have a GI illness of some sort. About 10 to 12% will have some sort of vaccination. The presenting signs, a change in sensorium, acute hemiparesis, long-tract signs, and kids having seizures and ataxia. Those are really the sort of the sine qua non of pediatric ADEM, and these are the symptoms that I always teach the residents of what we need to look for. The other thing I'll point out about this is meningeal involvement tends to be fairly high, especially in the younger kids. The kids at less than 5 years of age can actually look like they have meningitis and can look encephalopathic. So very, 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 very irritable. And in fact, some of them will be so irritable that they won't even walk. And so it sometimes brings up the specter of whether they also have something in their spinal cord as well. Hence the reason why I always usually not only MRI the brain, but also MRI the spinal cord in a lot of these kids. Visual loss tends to be much less common. It says 23% there in one study, but in my experience, it tends to be about more like around 5 to 10%. Radiologically, there are about 4 groups, but in general, what you see is you see a combination of sort of Group A and Group B. Group A is defined as these asymmetric and scattered what they call T2 or very white lesions on the MRI. They're just scattered in the gray matter and the white matter. And the other thing that you tend to see, I meant to say A and C, is you tend to see these bilateral symmetric lesions that are in the basal ganglia or the thalamus, and those sorts of combination of that MRI together, you tend to really makes you suggest that you're dealing with pediatric ADEM. The CSF findings in general, kids will have an elevated protein. Do 28% of the kids really have cells? Probably not. It's probably much less than that. But the thing that's very important about the CSF is that you do not see oligoclonal bands, and that's an important distinguishing characteristic for these kids. Treatment, for the most part, I treat this with 20 milligrams per kilo of solumedrol or some other sort of steroid, and that tends to be the norm for most of these kids. Some kids, there are some children that end up in the ICU, not as much as you would think, and ventilation is much less too. So, and seizures really only occur in about a third of the kids. So outcome, for the most part, is pretty good for most of the kids with ADEM. And in this study, there was a mean follow-up of about 6 years. And most of the kids, and this tends to be what I've found too, is that if they have neurological sequelae, they usually have either a hemiparesis or some sort of, not necessarily a mental handicap, but really more cognitive or learning disabilities for the most part. And you can also see symptomatic partial epilepsies or seizures during that time. Okay, and I think this will be probably the last thing I'll talk about, and then, yeah, because I'm at 1:58 right now, and I'll let Leslie tomorrow talk about TM. The one thing I wanted to point about, the reason why I went over ADEM is there's this multiphasic ADEM or biphasic ADEM, and it occurs in about 2 to 10% of patients. The age of the onset tends to be about the same as kids who have ADEM. But the point with most of these children is that they can have 1 or 2 relapses, and it's actually very usual in this younger group to keep going on and on and on, and to develop signs later on to have multiple sclerosis. But it can happen, and the mean intervals between relapses can be very, very long, usually between 2 to 3 years. these kids will continue to be negative for oligoclonal bands on the CSF. If kids go on to develop pediatric multiple sclerosis, they'll turn positive for the oligoclonal bands, and the CSF IgG index will be elevated, or the amount of antibodies you see in the spinal fluid will be elevated. So, and the follow-up period for these kids was about 8 years in this one study. So in summary, there's a number of different distinguishing characteristics that we look for on kids, in kids who have pediatric demyelinating disease. And multiple sclerosis and multiphasic ADEM can be difficult to differentiate, but there are certainly both some age parameters as well as CSF parameters that can help us differentiate between those two. Thank you.